Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thanks for listening to Behind the Knife. This is Patrick Georgioff, and I want to share an important message. Our oral board review kicks ass. We have over 100 scenarios with top-notch commentary to get you prepared for the exam, or maybe even just prepare for your next rotation. We're also adding over 30 new scenarios this fall and a brand new interactive video feature so that you can practice for the real thing. Get quick and easy access via our app for on-the-go use. It's still the best, and it is still significantly less expensive than anything else out there. Group discounts are available. Now, enjoy the episode and dominate the day.
Hello, Behind the Knife listeners. This is Cody, one of the Surgery Education Fellows. We're excited to be bringing you a new series here at BTK that will be some regularly scheduled conversations with the Editor-in-Chief of Annals of Surgery, Dr. Justin Dimick, where we'll be discussing contemporary research topics. Now, before I scare anybody off talking about research, we're not going to be debating primary endpoints for clinical trials or causal inference methods or any of the nitty-gritty stuff. These are going to be higher level conversations that are at a 30,000 foot view about contemporary hot topics in research in the field of surgery. For example, in today's episode, we will be talking about robotic surgery. We're excited about this new partnership and hope y'all enjoy the episode and the others that are to come. Thanks, Dr. Dimick, for joining us today. Dr. Justin Dimick is the Fredrick A. Coller Professor and Chair of Surgery at the University of Michigan and recently took over as Editor-in-Chief at Annals of Surgery at the turn of the calendar year. Thanks for joining us today.
Really excited to be here. Thanks for having me.
So today we decided we're going to talk about robotic surgery. I have to think that you and Dr. Lilimo at Annals receive a large volume of publication submissions on the topic of robotics. Is that fair to say?
Yeah, I think robotic surgery is one of the biggest innovations in surgery. Nationally, it's making its way into all clinical specialties. And so, we receive a lot of papers evaluating robotic technology for different procedures, evaluating its safety, effectiveness, and even introducing new robotics platforms and assessing their early experience.
Robotics has even caught the attention of Elon Musk a couple weeks ago, who informed all of us as surgeons that we're going to be replaced in the operating room fully by autonomous robots in the next few years. Any thoughts about that?
Well, I'd say maybe more than a few years. I once asked Dan Hashimoto, who's a national leader in this space, of what he thought the first innovation was, and he may be pushing a button to do a small bowel anastomosis or something that's fairly simple and straightforward like that, but you're still going to need a surgeon involved in a human, even as robotics advance, at least for the foreseeable future. And at least I hope so, as somebody who trains and ensures the safety of surgery.
And so just to remind listeners, can you tell us what your clinical practice looks like currently, whether you do or do not use the robot yourself, and the extent to which the department that you lead has integrated the robot into our enterprise?
So I am a minimally invasive and bariatric surgeon. My practice spans bariatrics, foregut, and abdominal wall. And I trained in air when there were no fellowships for that specialty, but I picked it up over time, and I learned to do everything laparoscopically. So most of everything I do is minimally invasive, but with a laparoscopic approach. I personally do not use the robot for surgery, but I lead a department that does. We've integrated robotics across most general surgery specialties at this point, including my own. And of course, our health system, which is broader than my own department. In urology and gynecology in particular, the robot has penetrated quite deeply.
All right, great. So let's start at a high level first. From your perspective and familiarity with the literature, what do you see as being the most compelling clinical advantages of the robot? And where do you think the perceived benefits have perhaps outpaced the evidence?
So to answer your first question, I think robotics has enabled things that are really hard laparoscopically. And I think probably the best example of that is robotic prostatectomy. That was an operation that was so hard to do laparoscopically that there were only a few people that could do it. And it's in a narrow space in the pelvis. The operation itself is technically complicated, with requiring suturing and anastomoses in a narrow, tight space. And so that introduction of robotics to that type of an operation revolutionized, and that's the standard of care, I would argue now, is robotic prostatectomy. I don't think that's even an argument. It is, and that's how urologists train to do it. That's how it's done. And I think the visualization, the wristed instrumentation makes that operation very feasible from a minimally invasive perspective. So that's probably the best use case. And so I'd say other areas where it has great utility are things that are really hard to do, and very few people could do them laparoscopically if that was the only technique available. So that's probably the best use case. On the other end of the spectrum, where I think they're less valuable, are operations that we've been doing safely a very long time laparoscopically, like laparoscopic cholecystectomy. When we transitioned from open to laparoscopy, there was a bit of a learning curve, but then we can do it safely as a field now laparoscopically. And introduced a robot to a very simple operation like that almost anyone can do laparoscopically safely if trained appropriately to do so. It just adds cost. And so I think that's if those are the two extremes of where it's most valuable and where it's least valuable, it's where you're replacing operations everybody can do laparoscopically with the robot.
Awesome. So robotic platforms are often marketed by companies and even the surgeons who use them religiously as being superior, but most comparative studies, particularly within general surgery and its subspecialties, show little to no differences in outcomes. And I'm not aware of any instances where the robots truly become the gold standard within general surgery. How do we interpret this tension of marketing and evidence?
That's a lot to unpack in one question. I would say that in general, the industry and people who manufacture devices or platforms like robotics, like their goal is to sell the product. And so they're marketing and they're always going to want it adopted more widely. That being said, they also enable advances, right? So, and we have to embrace both of those things. I think it's for people, for journal editors, for scientists to kind of find that middle ground and understand that these companies are doing research and development and funding innovation that's really important to our field. Surgical staplers being another example. But we have to figure out how to use them in a way that is evidence-based and value sensitive. And that's the challenge of leaders.
So shifting gears a little bit to now more towards skill set and training, how do you think robotic surgery has shifted or is going to shift the surgical skill set? Do you think we're actually at risk of losing our skills from the laparoscopic standpoint or from open approaches?
Yes, and I worry about robotics diffuse too far and our skills and our ability to train people to do laparoscopy atrophies, then we'll be existing in a world where we're performing low value surgery routinely. And that's not good for the health system. And the United States is fairly unique in how much we're willing to spend for healthcare. In other parts of the country, they think a lot more carefully about this. For example, in just north of us in Canada, there is a decision made about the value of robotics for specific conditions, and they purchase them regionally and allow them to be used where there's a high value use case. And that's obviously a much more rational way to approach this. And some countries don't have robotics at all because it's too expensive. Some countries can't afford laparoscopy. And so for, I think, us to think that it's free to use robots because we happen to find them freely when we walk into an OR, that's, I think, irresponsible from a financial stewardship perspective or healthcare costs. So my view in an ideal world is that we use robotics where it adds value and don't use it where it does not. And I do think that means we need to, as general surgeons, maintain skills in laparoscopy. And so as a department leader, I think carefully about wanting to have robotics present in clinical areas so that our trainees get exposed to it. And so that if there is evidence emerging that shows that it's superior in some way, we can quickly move into that space. And I think those are good reasons to have it partially penetrated in most clinical areas in a given department. But at the same time, I want our MIS fellow, minimally invasive surgery fellow, and our residents to graduate with strong laparoscopic skills in addition to exposure to robotics.
Makes sense. So you mentioned trainees, so let's jump into that a little bit further. Is there a ton of Behind the Knife listeners are trainees? I'm a trainee myself. And one of the things that I worry about is making sure that I have as broad of a skill set as possible so that one day when I eventually am on the job market, I'm as competitive of an applicant as possible. And if I was at a program that totally was replacing laparoscopy with robotics, I would worry that if the hospital that I was planning to work at didn't have a robot or didn't allow liberal use of the robot, and I didn't have those foundational laparoscopic skills, that I may not be a great applicant at that job because I don't know that I could go out into practice on my own and learn how to do complex laparoscopy. However, if the opposite were true, if I had strong foundational skills in laparoscopy and went to a job that embraced the robot and encouraged me to use it for lots of procedures, I think that, at least from a trainee's perspective, I think the learning curve would probably not be as steep to transition from strong laparoscopic skills to robotics versus the opposite. How do you think that trainees should be thinking about the robot and the programs that they might be considering training at?
It's a great question. And I'd say if I was a trainee right now in general surgery, I would make sure that I finished with strong laparoscopic skills if that was relevant to my specialty. And I would make sure I had exposure to robotics. And I think you're right in that it's harder to go back and learn laparoscopic skills because robotics is an enabling technology, right? We know that it shortens the learning curve for some things, enables things that frankly can't be done laparoscopically. And I'll give you an example of in my own division here. So doing a laparoscopic posterior component release or TAR procedure, like you just can't do that operation laparoscopically. At least somebody might be able to, but if they could, it would be a rare person. But robotically, it enables that. And so in my practice, I typically do recurrent hernias, and so I open their old incision and fix it through that. But if I see a patient who, perhaps a younger woman who has had several pregnancies and has a smaller hernia but has a very large diastasis and no incision, I'll refer that person to my partner, Jenny Shao, for potentially to consider a robotic or minimally invasive approach because it avoids having to have any abdominal incision whatsoever. And so I think that's it's a sort of narrow use case, even for someone who doesn't use a robot, but I'll cross refer to my partner who has that for that type of use case to avoid incision. But at the same time, it enables those procedures. And another trainee of ours, Vahag Nicolian, who is active on social media and I think takes a balanced approach in this. He'd argue, and I just saw him recently argue, that the adoption of inguinal hernia, so robotic inguinal hernia, is predominantly not amongst people who are trained and have strong laparoscopic skills to perform inguinal hernia repair. It's people that didn't do that laparoscopic learning curve, which is long for that particular operation. Mm-hmm. It's people converting from open to robotic directly because of the enabling technology of robotics. And so I think that's a very strong argument that more people could do more minimally invasive surgery with robotics. I don't think it says that I think it also argues that if you could do it laparoscopically, you should continue to do it laparoscopically because it's a well-earned skill set. You've made your distance along the learning curve, and frankly, it's a higher value operation if done laparoscopically. Probably the similar outcome. It should be the same operation. I think there's some data showing higher recurrence rates amongst robotic inguinal hernia repair, probably because people are earlier on their learning curve, but ostensibly it's the same operation being done minimally invasively with and without the robot. So once everybody's at the flat part of that learning curve, it just costs more to do it robotically, but it takes 250 cases, some say, to do it laparoscopically, and probably, maybe a tenth of that to pick it up robotically. I haven't seen data on that particularly, but it seems that people can learn it pretty quickly.
That might be a call for a future paper at Annals. Next, let's talk about some of the work that journals are publishing a lot about, and that's the learning curve. And we've talked about it a little bit earlier. In general surgery, what are the most important procedures in your eyes for learning the robotic platform safely? And are we currently proctoring and credentialing surgeons in the right way today?
Great questions. So if your question is where's the highest value use case, I think we think back to the robotic prostatectomy. It's things in tight areas that are technically complicated. And so I think we've seen great penetration in colorectal surgery, particularly for rectal cancer, rectal dissections, and particularly in challenging cases. The patient's BMI is high. Other just technically complex pelvic surgery makes great sense for the use case of robotics. Interestingly, there was a trial years ago that was laparoscopic versus open, and laparoscopic was found to not be non-inferior because there were violations to TME dissection, et cetera. And, my view on that is that it's probably a learning curve issue. And once again, when you're evaluating new technology, you have to make sure that the people that are participating in the trial are as experienced and high quality as the people doing the open, at least for an efficacy trial. We could talk about what efficacy versus effectiveness in real world data looks like, is that in the real world, people are at various different places in their learning curve, so that may look different, and a new technology may look inferior if you take people across the spectrum of their learning curves. But I'd say the colorectal is a very good place where there's a value case. I mentioned robotic abdominal wall already, but for complicated abdominal wall, things that you can't do laparoscopically. And I think that for a small umbilical or small epigastric hernia, like no one's proven to me yet that like an IPOM, which takes 15 minutes, is not highly effective and high value to be done laparoscopically. Starting to open up the layers of the abdominal wall and do big dissections and lay big pieces of mesh in the benchwork to space. Like haven't seen any data suggesting that that's a better way to do that operation yet. Whereas I think there is some data that doing those retrorectus repairs for larger hernias, and especially where you reconstruct the core, I think there's good data to support that.
So now, taking off your editor-in-chief hat and putting on your health system leader hat as a chair of a busy clinical department, how do you think about the financial trade-offs of robotic surgery? Does it make sense at the system level when considering the acquisition, the maintenance, the cost per case of disposables? Is it procedure specific? Is it a volume thing? Can you just tell us a little bit about how you think about that?
Well, I'd say I have several different hats that I wear when I think about robotic surgery. I have like my own individual surgeon hat, which we got have a spare time. And, in that regard, I said I believe as a profession, we should maintain laparoscopic skills amongst our trainees and our surgeons, because to do everything robotically is just not a high value approach until there's evidence to show that. As a journal editor, that hat I think about fostering a forum for honest discussion about evidence, effectiveness, safety, learning curves, and the value of these operations. As a health system leader, and especially as an academic health system leader, I think there are different reasons to do or to not do robotics. I've mentioned some of them, but I'll just go through them kind of systematically so we can think about it in that way. I think from a clinical innovation perspective, like we are an academic health center, we have to be on the cutting edge of clinical innovation. And so therefore, if people are generating evidence and pushing the envelope with robotics and different clinical specialties, I want those people in my department, right? Because we need to be pushing that envelope clinically, advancing the field and studying it, right? That's part of our job as an academic health system. I mentioned the training piece. I want to have robotics across all specialties so people get exposure and they're trained in case it flips. And that's the best way to do things. The evidence shows that. But I also want them exposed to laparoscopy. And that's one of the reasons I haven't adopted robotics myself, is because as we hire younger faculty, a lot of them are really enthusiastic and want to engage heavily in robotics. And that's great for the reasons I just mentioned. But at the same time, some of us have to continue to do things laparoscopically. And so, myself, Dr. Tom, my chief of general surgery, are not engaging in robotics. We're kind of pushing on the laparoscopic, keeping us at the frontier of skill generation on laparoscopy. The value piece is really interesting. I haven't seen an analysis of this. There was recently a paper that came out in Surgery that Kyle Sheets and I wrote the editorial for. We called it A Robot in the Room, Time for an Honest Conversation About Value. And this was around laparoscopic cholecystectomy. And they basically showed that the disposable costs, just disposable, so take out the capital costs of buying robotics, just the exposure costs were several fold higher for robotic compared to laparoscopy. And I haven't seen a study yet that looks at the profit margin, but if I was to guess on what I know about profit margins for these smaller cases, is you probably lose money anytime you use a robot to do a chole or a inguinal hernia repair. I'm currently looking for a data source where I can study that. And because if it flips from profitable to unprofitable with the use of the robot for simple things, that would create the value use case for maintaining, do them laparoscopically. Of course, there is some safety data to suggest that biletal injury rates are higher, even for more complicated cholecystectomy patients. That's recently a paper I believe you wrote. It was in JAMA Network Open, and that paper kind of put to rest the argument that like for more complicated patients, people are using the robot, and that's why it's confounding. And it's probably, like I mentioned before, it's because people are on the learning curve, right? And the learning curve for robotic chole is pretty steep. We've seen that as well. So you could make in the setting of something being less safe or people not being adequately on the learning curve, like there isn't really a value case there. It's just you shouldn't be doing something less safe, right? That's clear. But as I've said, once people get up on the learning curve and they're very good at these things, there is a value case to be made. And I've spoken to chief value officers at large healthcare systems, and who would have known, like when we were publishing this data showing that outcomes are equivalent, where outcomes are maybe even worse for robotics and the learning curves, like that one of the chief consumers of that is chief value officers who are trying to reconcile the demand for more and more robots, but are doing the value analysis and seeing how much it costs. One of our recent fellow graduates was told by the hospital he's working at that he can use robotics for complicated things like foregut and complicated abdominal wall reconstructions, but not for choles and lap inguinals. Of course, he's trained to do lap inguinals coming out of our program, so doesn't need the Blowbot to do that.
Right. So, lastly, as I understand it, you're starting a new section within Annals of Surgery on clinical innovation, which seems like a topic that might be ripe for publishing in the future, some robotic surgery research. Is that right? Can you tell us a little bit more about what's to come at Annals?
Yeah, so one of the new innovations as a new editor-in-chief we're putting in place is we're going to have several short-form articles with the section editors who will cultivate them, one of which, as you mentioned, will be around clinical innovation. I'm still looking for an editor for that section, so if you're interested, send me an email. If you can, you find my email on the World Wide Web. And the very first series that we're going to be publishing in that section is a state of the evidence for robotic surgery. So I'm currently soliciting articles from each clinical specialty, primarily focused on general surgery, but there'll probably be some thoracic and other surgical specialties that come out of general surgery as well. But if you're interested and you think you have a good grasp of the state of the evidence, I'm looking for not a propaganda piece and not a hit piece. I'm looking for the honest state of the evidence for different areas in general surgery. So if you're interested, also send me an email. I'm soliciting those now, and I'd love to have potential authors emailing.
Awesome. This has been great. We at Behind the Knife are super excited about this new partnership with you, Dr. Dimick, and everyone at Annals of Surgery, and are looking forward to our next conversation to come soon.
Great. Thanks for having me. Looking forward to it. Dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.